Today's lecture is on urinary tract infections in children. So you may have seen these sort of children in your private practice, or maybe your cousins or children may have had UTIs. So important thing is whether how you have treated them is important. Most of the time we see children being treated for UTI, but urine culture was not sent before starting the treatment. And how many days you are going to treat? So if you don't treat them properly, what are the problems they can have? So we are going to talk about those during my lecture. Tell you the importance. So highlight the importance. I'm going to start with one of the actually this child I have seen a few years back when I was a senior registrar. This child was seen at 1 year of age at the cardiology clinic. Boy came for a follow-up echo. So at that time, at LRH cardiology unit, they routinely check the blood pressure before doing the echo. So when they checked the blood pressure, it was high. So as a result, they referred this child to our unit, and there we investigated to find the cause for the high blood pressure, and we have detected that this child was in chronic renal failure. So looking back, when we look back into the past history, this child was treated during the neonatal period for sepsis in NICU, and also ventilated for a couple of days. And at that time they have done echo, and it showed left ventricular hypertrophy. That's why they came for a follow-up echo at 1 year. So unfortunately, this child's blood pressure was not checked up to 1 year of age, and by that time child had established chronic renal failure. So we can assume that this baby during the neonatal period might have had UTI, and due to the complications complications of UTI went to renal failure. So this story highlights the importance of treating the UTIs properly and managing the complications. For example, if you have controlled this child's blood pressure properly, we could have prevented this chronic renal failure. And this unfortunate child, after a couple of years, died at ICU at LRH due to complications of chronic renal failure. What is the commonest organism causing UTI in children? Sorry? E. coli. Yes, E. coli is the commonest organism causing UTIs. Up to 80% of the UTIs are caused by E. coli. And if you are given an option, say you are going to have a UTI and you can select the organism, E. coli, would you prefer E. coli or some other organism? Which one is better? Why E. coli is better? So studies have shown that UTIs caused by other organisms lead to there's a higher chance of them getting renal scarring and kidney problems later, right? So E. coli is better in that regard, right? And what is the significant growth in urine culture? Yeah, so more than 10 to power 5. So why 10 to power 5 and why not 10 to power 7 or 10 to power 9? Right? So actually there was a person who lived some time back in 1959. His name was Cass, and he decided he worked in a lab. For the lab convenience, he thought of taking 10 to power 5 as the cutoff. So it was not based on any research. So for the lab convenience, just only for the lab convenience, he took 10 to power 5 as the significant growth to say this child is having a UTI. In fact, studies done later have shown in a true urinary tract infection, there will be up to 10 to power 7 to 10 to power 9 organisms or colony forming units, right? So when we take 10 to power 5 as the cutoff, actually we will be like overdiagnosing by 50%, right? So true culture positive UTI, there will be more than that amount of organisms, 10 to power 7 up to 10 to power 9, right? So how do these children present? Children with UTI, how do they present? So neonates are not just small kids, they are like different entity, right? So they have different ways of presenting. Older children, how do they present? So smaller ones who are not like who can communicate, like small children, maybe 1 year, 2 years, less than 2 years, they can actually, how do they present? They can have like recurrent febrile episodes without any focus, right? Recurrent febrile episodes, right? So they sometimes they will cry when passing urine, and older children will complain, like they will say there's discomfort when passing urine, and so on. Right. So neonates, how do they present? Neonates with UTI. Even bigger kids even can present with bedwetting, newly onset bedwetting, right? Neonates, they present differently, like they can come with fever, and they can come with prolonged jaundice, prolonged yellowish discoloration of the body. If you check SBR, it will be a direct hyperbilirubinemia. And they can have failure to thrive. So when we chart the weight in the growth chart, you will see there's a failure to thrive. So then there are some investigations we are usually doing, so that urine culture is also included in that set of investigations. So that's how they present. And have you all heard about these terms called bowel and bladder dysfunction? So this is often most of the time we disregard about these problems, but they can also predispose to urinary tract infections. For example, constipation. Most of the time it's due to poor dietary habits. As you know, these organisms are coming from the GI tract, ascend from the GI tract. So if there's constipation, there's a high chance of them getting UTI. And bladder dysfunction is, for example, like some children, when they go to school, they are very reluctant to use school common toilets, right? So what they do is they drink less and avoid going to the toilet, and they withhold urine. So that can predispose to UTIs. And what are the things you examine in a child with UTI? What are the important points in when you examine these children? Anyone? So any child, we have to check the growth parameters, and we have to check the blood pressure. And abdominal examination, they may have flank pain or renal angle tenderness, masses, and sometimes meningomyelocele. You have to have a look at the back also, which can give rise to neurogenic bladder. And very important to have a look at the genitalia in both males and females. So male babies, they can have what you call non-retractable prepuce, right? So when the prepuce is non-retractable, organisms can harbor inside this prepuce, and if we do a culture, it might come as positive. It's just due to the colonization. That is not a UTI. Okay? And female babies, they can have labial adhesions, right? And they can have UTIs due to that, right? So how do you investigate and treat UTI? What are the investigations we do on these children? UFR. Imaging. Yeah, ultrasound scan. So if you see national like in NICE guidelines, they might not recommend to do a routine scan for each and every child with UTI because that is their situation is different. But in our setting, all the children who are having UTI, culture positive UTI, they have to undergo a ultrasound scan of the KUB, that is kidney, ureter and bladder. Why is that? In UK and other developed countries, they do these mothers when they are pregnant, they undergo a CR scan. And I have seen when I was working in UK, like they come with a plan actually. If they detect any renal anomaly, they will say like do this after delivery, start them on prophylaxis, arrange a postnatal scan and refer to the nephrologist or referring center where there are specialists on renal problems. So like that they give a plan. But in our setting, not every child they don't undergo CR scans like that. So as a result, in our setting, it's advisable to do a ultrasound scan for each and every child who develop a UTI. Culture positive, mind you, culture should be positive. Right. And then how other investigations include MCUG, micturating cystourethrogram, and DMSA, and if there's any obstruction, DTPA, IBU, and MAC3 scans. So we'll discuss about them later. And how to treat, we'll talk about later. And what will happen if you don't treat them properly? So what will happen if you don't treat the UTI properly? What are the complications they can have? So they can get so if you get a wound, if you get an injury in the skin, you get a scar there. So like that. So growing children up to around 4-5 years, when they get UTIs, these kidneys grow until around 4-5 years. So during that time, if there's a UTI, they get a similar scar in the kidneys. And if there are recurrent UTIs, there's more risk of getting more and more scars, and eventually they can lead to hypertension, proteinuria, and even end-stage renal disease and renal failure. Right. With those questions, we move on to my presentation. Just to get your attention, I have put those questions. Right. Okay. So this is the overview of my lecture today. So I'll be talking about epidemiology and risk factors, clinical features and diagnosis, and UTIs in neonates, cystitis, acute management, imaging and prognosis, and long-term management and prevention. So UTI is a common important problem in childhood, and actually you can divide them UTIs as upper tract UTI and lower tract UTI. So what is severe is the upper tract UTI. We refer to pyelonephritis. So that sort of a UTI, they can have complications later on, like renal scarring, as I mentioned before. Lower tract is like cystitis, which is less severe in nature, but in children, clinically it's very difficult to differentiate between the two. So we have to have some idea about the prevalence and presence of risk factors for UTI and for renal scarring, and then we can guide our test according to those risk factors. So overall prevalence of UTI is around 7%, and it is affected by various factors like age, race, ethnicity, sex, and circumcision status. So prevalence is highest among boys who are young, like up to 3 months. Less than 3 months, the prevalence is high. And white children, for reasons that are not very clear, they have a higher prevalence than black children. Girls again have a 2 to 4-fold prevalence, higher prevalence than circumcised boys. Right. So white girls with high temperature have a UTI prevalence of up to 16%. So what is the microbiology? So as we discussed earlier, most of the UTIs, up to 80%, is caused by E. coli, right? So what are the other organisms which can cause UTIs? They include other gram-negative bacterial pathogens are listed there: Klebsiella, Proteus, Enterobacter, and Citrobacter. And gram-positive bacterial pathogens include Staph Staphylococcus and Enterococcus and Staph aureus. So, as I mentioned earlier, infection with an organism other than E. coli is associated with higher likelihood of renal scarring and complications. And how does these problems happen is like these organisms, like as I mentioned before, they originate from the GI tract and they ascend along the renal tract, and they mount inflammatory response in the kidney. As a result, they develop renal scarring. So other viruses can also cause UTIs like adenovirus, enterovirus, Coxsackie virus, and echovirus. And fungi can also cause UTI, but these are uncommon causes for UTI. Viral UTI usually limited to the lower urinary tract. So you may have seen these children, actually they come with what we call features of cystitis. So viruses can cause what is called hemorrhagic cystitis. So these children come with like gross hematuria. So but it lasts for only for few hours or so. Right? They will have like red color urine in the morning. By afternoon it will clear off. Right? But again, when a child comes with a picture like that, we have to exclude other sinister causes, right? So it can be, so when they come with, what are the other possibilities when they come with gross hematuria or red color urine? So it can be due to it can be due to a systemic problem like low platelet count, or if the child is in DIC, they can have blood in the urine. In fact, like any significant infection can give rise to few red cells and few amount of white cells in urine. And in the kidneys, it can be a problem due to the kidneys, problem in the kidney like glomerulonephritis can give rise to hematuria, red color urine, or it can be a renal tumor or renal calculi, right? Then again it can be a problem in the ureters. There can be growths or stones stuck in the ureters, or it can be a problem in the bladder like in hemorrhagic cystitis, or even it can be due to a problem in the urethra, right? So we have to exclude all the other things and sinister things, and there's a way of detecting where these red cells are coming from. So if you look them under microscope, you will see if they are coming from the kidneys, you will see red cell casts and dysmorphic red cells, right? But if it is due to hemorrhagic cystitis, you won't see those things in the urine microscopy. So fungal UTI, usually children with immunosuppression and long-term use of broad-spectrum antibiotics, and children who are on long-term catheterization, such patients will get fungal UTIs. So as I mentioned before, most of these UTIs or organisms originate in the GI tract, and but in certain group like neonates, they can have bloodborne spread, right? So what the first step of developing a UTI is this organisms colonizing in the urethra. Then they will ascend, and certain bacteria have this what you call virulence factors. Like for example, E. coli hope you can remember, it has this fiber like villi, and they help them to adhere to the cell surface, and subsequently they ascend to the kidneys and cause this inflammatory response. Right. So host factors can also affect UTIs. So age. So prevalence of UTIs, as I mentioned earlier, highest in boys younger than 1 year and in girls less than 4 years of age. Lack of circumcision, again, uncircumcised male infants have a higher like prevalence, like 4 to 8-fold higher prevalence of UTI. But having said that, to prevent a UTI, so studies have shown you have to do, to prevent one UTI, you have to do circumcision in 111 boys to prevent one UTI, right? So it is not routinely recommended to do the circumcision in the aim of preventing UTIs. So female infants have higher prevalence. We think that is, we assume that is due to shorter female urethra, but again there are other contributory factors. Race and ethnicity is also, like I mentioned earlier, white children have higher prevalence. So genetic factors also contribute for UTI. For example, first degree relatives have a higher likelihood of getting UTIs. This may be like correlating with like VUR, vesiculated reflux, can also be familial, so it may be related to that. And again, adherence of this bacteria to the uroepithelium, there may be genetic factors involved. And a few words about urinary obstruction. So obstructive urologic abnormalities are at increased risk of developing UTI. Why is that? Because the stagnant urine is a good culture medium. So predisposing obstructive abnormalities include the following, like anatomic conditions like PU valve. So hope you have heard about this posturethral valves or uretero-pelvic junction obstruction. So PU valves, it's very important to exclude in newborn babies, neonates and infants, male infants. It's very important to ask the mother about the urine stream. So this it happens only in males. So they have this. Some of these children have this. There's a valve in the posterior part of the urethra. So if you miss it, it can give rise to reflux, and can result in renal scarring and renal damage. Right. So very important. So if there's a posturethral valve, the urine stream will be poor. Right. If they have a good stream, it's unlikely, right? And neurologic conditions like meningomyelocele can also give rise to UTIs. For example, they have, like, if you do a contrast study or MCUG in these children, they will have very trabeculated bladder wall, and contrast study will show what you call the Christmas tree appearance, right? And then other functional conditions I discussed earlier, like bladder and bowel dysfunction. So abnormal elimination when we talk about bladder and bowel dysfunction, so it includes abnormal elimination patterns like frequent or infrequent voids, daytime wetting, urgency, infrequent stools, and right, especially like if these are like new onset symptoms, they can predispose to UTIs. You have to think about UTIs. And withhold immunovirus I have discussed earlier. So we think these are due to behavioral abnormality of the function of the muscles in the pelvis, bladder, and the sphincters. So what is vesiculated reflux, VUR? So VUR is retrograde passage of urine from the bladder to the ureters, right? It is the commonest urologic abnormality in children, and there is increased risk for these children to have UTI. And in girls, females, like sexual activity can also be associated with UTIs. So this picture shows VUR grades actually. So this is the bladder, right? So these are higher grade, grade 4 and 5. So these grade 1 and 2 are less likely to cause renal damage, but higher grades can result in renal damage. And most of the time these low grade ones resolve spontaneously with time. And studies have shown even these higher grade ones can resolve with time. But sometimes we have to do surgeries, correct them in like maybe grade 4 and 5 children with grade 4 and 5 reflux. So bladder catheterization again can predispose to UTIs, and so if you catheterize the child or any patient, you have to get rid of the catheter as soon as possible, right? So what are the risk factors for renal scarring? So renal scarring is the loss of renal parenchyma between the calyces and the renal capsule, and it's a complication of UTI, and it can give rise to all those complications I mentioned before: hypertension, decreased renal function, proteinuria, and stage renal disease. And this is how you see the scarring in a DMSA scan, that is a posterior view. General risk factors for renal scarring include recurrent febrile UTI and delay in the treatment of UTI, acute infection, especially if it is a febrile UTI. So if you have seen a child with UTI, if you did not treat properly, if you have treated with few days of antibiotics, 3 or 4 days antibiotics, so that child can go and going to have renal problems later. And bowel and bladder dysfunction can also give rise to renal scarring. Obstructive urinary tract malformations we talked about earlier, and VUR. Again, studies have shown renal scarring was present in up to around 15.5% following UTIs. Predictors include VUR, especially high grade VUR, and if there is any abnormality in the ultrasound scan of KUB, and if there is a marked inflammatory response, for example, if the WBC count or CRP is quite high, and if temperature is high, more than 39, and organisms other than E. coli. So how do you, what are the clinical features and how do you diagnose UTI? Clinical features and diagnosis. So how do you define a UTI? So it's defined as significant bacteriuria in a clinically relevant uropathogen. So there should be organisms we take as 10 to the power 5, even though true UTI will have a higher number of organisms in a patient with triuria. So organism should be there, and pus cells should be also there in the urine. And fever may be the only sign, as I mentioned earlier, in infants and young children. And older children, as I mentioned before, they can have other symptoms. And what are the things you examine in these children? So you have to measure the temperature, blood pressure, growth parameters, abdominal tenderness or mass, absence assessment of suprapubic and costovertebral tenderness, and external genitalia. Have a look at the back to look for any spinal problems, and you have to also look for any other sources of fever. So what are the tests you can do in these children? They include, in our setting, most of the time we do a UFR and urine culture, but in other countries, and it is sometimes available in our setup as well nowadays, dipsticks can be used, like it will show nitrites and sometimes white cells. So how do you take this urine culture? what is the method of taking a proper urine culture, and each age group, how do you take the urine for culture? Can anyone tell me how do you take a midstream urine sample for culture? So you have to wash the genitalia properly with soap and water, and then actually you have to discard the first bit of urine, and then without touching so you have to keep that container open, and you should not keep the lid on this table or here and there, so the organisms there will grow in that culture plate, and then you have to collect the sample, and then as soon as possible you have to send it to the lab. If there is a delay in sending to the lab, what do you do? You can put it in actually what you call boric acid. If you remember your medical faculty days, so you can put it in boric acid, or if you collect the sample at night, you can keep it in the fridge, not in the freezer, in the door, and send to the lab in the following day. So especially children who are not toilet trained, but if it is a toilet trained child, you can go for a clean voided specimen. These sterile bags, sometimes I have seen these bags being used, like you can stick that bag to the genitalia, so you should not go for that. I can remember in UK they had some other ways of collecting. They use these potties, clean potties. They clean with not with antiseptics. You can clean water, and you can collect that sample. Or they have what you call urine pads. So you can, there's a sponge. You can keep it under the pamper in the genital area, and every 15 minutes you have to check whether the child has passed urine. If it is wet, you can extract the urine using a syringe from that sponge. Again, those are not the best method to collect that urine sample. So diagnosis, as we discussed earlier, so significant bacteriuria, if a midstream urine sample grows more than 10 to power 5, it is significant, but it is different to a catheter sample. Catheter sample is you take as positive if half of that is their colony-forming unit, more than 50,000. And suprapubic aspiration, any amount of organism, any number of organisms, or colony-forming unit more than 1,000 will be taken as positive. And then pyuria you can check from microscopy or using dipsticks. So sometimes children can have asymptomatic bacteriuria, for example, like prepusal colonization, or sometimes other systemic illnesses, as I mentioned earlier, can like due to that they can have pus cells in urine.